Thank you, Dave. I'm going to be speaking about short-stay knee arthroplasty and discussing some of the relevant aspects of our case. I have no disclosures. And I think we all know that arthroplasties are increasing around the world. And in the US, we've already exceeded more than 1 million arthroplasties per year in the United States. And we know that the costs of arthroplasty are really high. And so even several years ago, the US exceeded tens of billions of dollars spent on knee arthroplasty per year. And so there's been a heavy emphasis within health systems around the world to really focus on value and not volume. And so as part of that, we've looked at different creative ways to decrease the cost of care. Now at our institution, where we have an on-campus rehab facility, we looked at direct admit for certain healthy joint replacement patients to go from post-anesthesia recovery to our on-campus rehab unit, as opposed to spending their recovery on the inpatient surgical ward with much more intensive nursing care. And as you can see from the bullet point at the bottom, that this actually resulted, when we looked at cost analysis retrospectively, of about $10,000 US per patient, which I think is significant. Now, there's been a move within the US to go to same-day outpatient knee arthroplasty. And more recently, knee arthroplasty was removed from what was referred to as the inpatient-only list for Medicare. But I think the cost savings really depend on the health system. In Canada, in the article on the top, you can see from the Canadian Journal of Surgery, the estimate for the Canadian health system, which is a socialized medicine system, is about 30% of cost savings compared to inpatient stay. In the United States, when you look at the article at the bottom, it's a little bit more complex in that, without going into too much detail, in the United States, hospitals and healthcare practitioners are actually paid differently or separately. And so while a hospital may save $1,000 switching knee arthroplasty from inpatient to outpatient, the clinicians actually lose more than $3,000 when a knee replacement is performed on an outpatient basis. In addition, while we talk about cost savings, it's really important that we focus on not losing quality of care. And this is an important article published fairly recently from our friends and colleagues at the Hospital for Special Surgery. They used a database to look at hundreds of thousands of patients who had arthroplasty, either discharged the same day with a length of stay of 0 versus patients who had a more traditional inpatient recovery stay. And you can see from the bottom paragraph that patients who had a length of stay of 0 or same-day discharge actually had more complications after surgery, specifically cardiac and pulmonary complications. However, many factors have affected the way that we care for patients. And COVID-19, of course, has led to the cancellation of elective surgeries. And at our institution, we were prevented for months for having elective surgeries that required inpatient admit. And so at our institution, we actually initiated a same-day knee arthroplasty program that was actually the idea of our anesthetists. When we looked at ways that we could design that program, we looked to this collaborative article that I wrote with Drs. Lee and Rubin at Yale. Dr. Rubin is an orthopedic surgeon. We looked at the important factors when it comes to selecting patients first, because not every patient is a good candidate for same-day discharge, much less short-stay joint replacement. And when you look at the criteria, it's important that patients have unilateral surgery, that they be relatively young, relatively healthy and functional, and not anemic, and have great social and family support. Because remember, the costs and the burden of care after surgery for short stay and outpatient arthroplasty shifts from the hospital to the home. And so for our patient, we do need a little bit more information. While she's obese, we don't know what her BMI is. We don't know if she has other serious end organ dysfunctions, such as sleep apnea or cardiac disease or pulmonary disease. We don't necessarily have a good appreciation for functional status because she does have chronic pain, and this may limit her functional ability due to pain. And we also don't know the social support system. And I think this is really the most critical. While it is important that we look at the medical history of a patient, the ability to actually transition in terms of social support is really necessary in order to prevent downstream healthcare utilization. In terms of the elements of the practice, it's important to have very skilled surgeons, and the anesthetists involved have to be comfortable with regional anesthesia techniques and multimodal analgesia. In terms of intraoperative care, I think we have great guidance from these international recommendations from the Icarus group. And for patients who have knee arthroplasty, like our patient, neuraxial anesthesia is recommended. And I think based on the strength of evidence, which was low, the recommendation is judged as weak, but that still is based on associations of positive benefits with neuraxial anesthesia in terms of decreased complications after surgery. This was true for knee replacement patients only when the neuraxial anesthetic was the primary anesthetic and not combined with general anesthesia. In contrast, for hip arthroplasty patients, neuraxial anesthesia is recommended even if it is combined with general anesthesia. Both combined neuraxial with general and neuraxial alone for hip arthroplasty patients has actually been shown to be better than general anesthesia. Neuraxial anesthesia is really the only opioid-free option for patients having this kind of major surgery. And in our institution, we avoid neuraxial opioids due to our institutional requirements for postoperative monitoring. For every patient having knee arthroplasty, you have to start with multimodal analgesia, non-pharmacologic interventions, non-opioid systemic interventions, even opioids. And in this case, local and regional analgesia is actually only one row on the table. And so although we all love regional anesthesia, we have to acknowledge that not every single patient has access to regional anesthesia. And so local anesthesia by someone, including the surgeon, should be considered part of the multimodal regimen. The knee is innervated by multiple nerves, and we'll be talking about some of these specific techniques during the practical part of the symposium. But needless to say, there are many, many, many options. And if you go from the least specific, such as neuraxial, to the most specific, arguably targeting those distal and peripheral branch nerves, or so-called genicular nerve blocks, then we have many, many options to offer patients. And because, as I mentioned, not every patient has access to regional anesthesia, we have to include local infiltration by surgeons as a potential option for local anesthetic delivery. However, if you have access to regional anesthesia, then I think that it is safe to recommend that every patient having knee replacement, including our patient, should have something in box A, either a nerve block or local infiltration by a surgeon, which can be replaced by genicular nerve blocks by anesthetists. And if you have available a skilled service, then you can add an optional item from box B. So that means that nerve blocks can be combined with surgeon infiltration, that nerve blocks can be combined with an IPAC, because there is evidence that shows that local infiltration alone is actually improved when nerve blocks are added. And so I think that we have several options to offer our patient, and we'll talk about some of the practical approaches very soon. Back to you, Dave.